Hello, everyone. This is Jeff Sparks, rheumatologist at Brigham Women's Hospital and Harvard Medical School in Boston. And I am here with QD Clinic as part of the ILD campaign for the month of September 2025 with RheumNow. And we are going to talk about bronchiectasis in rheumatology. And I'm going to talk to you about a patient that I had seen and some of the difficulties that can come from this. And this patient is a patient with rheumatoid arthritis and bronchiectasis. This is a 68-year-old woman with seropositive RA, strongly seropositive CCP and rheumatoid factor. She's had RA for about 10 years. Joints overall doing pretty well, but she's been on a couple biologics. She's on tocilizumab and methotrexate and a little bit of prednisone. And she's a bit on the frail side, underweight, and she saw me saying, "Yeah, my joints are feeling okay. I can't come off of prednisone. I'm stuck on 3 milligrams, but I've, had this nagging cough, and I'm sometimes coughing up sputum. She doesn't do much around the house. She doesn't have stairs. She's pretty sedentary, doesn't work out, hasn't lost any abrupt weight. She's always been a bit on the thin side." And so I was confronted with, here's someone who has a cough and sputum, and certainly the differential is quite wide there. And she didn't really complain too much of shortness of breath. Certainly the first thing to do besides a history is do auscultation. And she basically had some rowels, did not feel like she had crackles, but sounded a bit junky. And the next thing that I would do is get imaging and PFTs. So she had bronchiectasis. Um, it looked to be kind of moderate in severity, diffuse across both lungs, and PFTs also showed some obstruction. She's a non-smoker, by the way, and she's someone that's been immune suppressed. She's stuck on a little bit of steroids. She's on both methotrexate and um, tocilizumab. And so you certainly worry about infection. And, these are the patients that I think kind of keep you up in the middle of the night because she's someone that kind of has a poor baseline. And, a pneumonia can really push her over the edge. She could get admitted or even worse. And is she brewing a pneumonia? Is this like a viral infection that's persistent? Is she colonized? Um, so, you know, this is a patient where you might even think about Z-Pak, azithromycin. Minocycline is actually, has some efficacy in rheumatoid arthritis and certainly might help out with infections as well. It's a rare patient, but maybe a patient with, bronchiectasis and infection might be someone where you even think about something like that. So as far as what happened with this patient, we got the CT scan and PFTs that I mentioned. This continued to linger. I'll mention she did not need oxygen. She did not desat when walking, but it basically continued to linger, and you started to worry about um, mycobacterial infection, maybe cancer, maybe other things. So I did send her to pulmonary, who decided to do a bronchoalveolar lavage, which really did not show a chronic infection. There is this Lady Windermere syndrome of, chronic MAC, and you've probably heard or even seen patients that have bronchiectasis and MAC and RA, and you get into this chicken and egg debate about whether the MAC caused the bronchiectasis or the bronchiectasis caused the MAC, and it's really hard to disentangle these patients. And I will say that this is not an uncommon scenario. Our data show that around 10 to 15% of patients have some bronchiectasis, even isolated without ILD, and we really don't know what to do with these patients. Um, Certainly, they are at risk for infection. They have, mucus buildup in there and floppy airways, so they can get pneumonias, viral infections, bacterial infections. So certainly making sure they're vaccinated, but reversing this is really not possible, at least at this moment. There are some medications being trialed for bronchiectasis, in particular DPP-1 inhibitors that had a positive phase 3 trial. However, immune suppression was a exclusion criteria from those trials, so it's not clear how that would help out apply to patients with RA that are on immunosuppression. So really for these patients, unfortunately, you're trying to Be vigilant about vaccination, trying to treat infections that happen, certainly thinking about inhalers, um, you know, respiratory, referring them to pulmonary, following to make sure that things don't progress, making sure that they don't have ILD. And, if you can, trying to offload the immunosuppression in order to decrease that infection risk. We recently had a paper that showed that bronchiectasis really increases the risk of serious infection. And otherwise, it's really reassurance that, a lot of these patients, while they have quality of life impact, often it does not get much worse. And again, trying to keep the RA disease at bay while minimizing immunosuppression. So hopefully you can see here that bronchiectasis is a tough problem. We need a lot of solutions. This is probably something you've encountered with before. The thing we worry about is infection. We really need more treatment options. So this was RA and bronchiectasis in the QD clinic with RheumNow, and thanks for your attention.